Without further ado, I wanted to talk about a relatively poorly known condition or topic that we define or name as relative energy deficiency in sports, which I'll abbreviate as RED-S. The tale of RED-S cannot be told, however, without starting with its origin story. So let's hop in the Wayback Machine. Let's go all the way back to 1993, before social media made us all anxious. And we benefited from the brilliant minds led by Dr. Barbara Drinkwater, very well hydrated, who described this condition of the female athlete triad. And what Dr. Drinkwater and her team discovered was that there was this very intimate relationship between disordered eating, amenorrhea, and osteoporosis. So let's unpack that a little bit. Disordered eating, that's not just bulimia, anorexia, that's also things like caloric restriction, fasting, diet pills, laxatives, diuretics. Amenorrhea, that is simply put the lack of menses. We can further break that down into primary and secondary. Primary being when a female fails to achieve menses by age 15 or within 3 years of breast development. Or secondary is if they've had regular menses and then they stop having menses for a 3-month period, or they had one spontaneous menses and then don't have another menstrual cycle for 6 months. And then osteoporosis, we're all well aware of that, weakening of the bone. And so we have to examine why are some athletes more likely to engage in disordered eating. So there's many different contributing factors. There's societal standards, right? So these athletes are seeing pictures of Olympians and professional athletes on TV, social media, and they have 2% body fat. They're ripped, they're shredded, and they internalize that. They think that I need to look like that if I'm going to achieve that level of success. There's also sport-related pressures. There's increased emphasis placed on body weight and body fat. There's pressure from multiple different angles. There's parents, coaches, judges that are pressing pressure on these patients and athletes. A lot of elite athletes are also a little bit perfectionists, right? They put a lot of internal criticism on themselves. A lot of, especially adolescent athletes, also don't really know what's right and wrong, right? So there's a lack of nutrition knowledge. A lot have this impeccable drive to win. They'll do anything it takes to be the best. And then there's also the negative consequence and impact of injury. We will see chronic dieting in these athletes. They often will unfortunately suffer from low self-esteem and depression. And unfortunately, there may be an underlying history of family dysfunction or sadly physical or sexual abuse that may be underlying. And then there's various biological factors as well. So amenorrhea is a very complicated topic to boil down into 30 seconds. So just to kind of put this in a nutshell, right? So what happens in these athletes, and there's many different reasons why individuals experience amenorrhea, but for the topic of this conversation, right, we're focusing on low BMI or body weight. And what basically happens is a functional menstrual cycle depends on a healthy HPG axis, this complicated feedback loop between the hypothalamus in the brain, the anterior pituitary in the brain, and then the gonads, the ovaries. And what happens in these athletes is there's a disruption or an interruption in that cycle, in that pathway, and these hormones and neurotransmitters are not being secreted and released as they are meant to, and the end result is that they are not ovulating and they're not producing enough estrogen. And when you don't have enough estrogen, you lose the beneficial effects of estrogen, which results in reduced bone mass and increased rate of bone loss, which leads to weakening of the bone. So what athletes are at risk for this type of condition? So many different types. Sports with subjective scoring, those that engage in endurance sports, sports that require body contour revealing clothing for competition, sports using weight categories for participation, and sports that emphasize a pre-pubertal body habitus for performance success. So let's fast forward a little bit now, all the way back to 2014, and we wisened up a little bit. Yes, disordered eating is really important and often paramount to this condition. However, it's not really the disordered eating that's ultimately the problem. It's the result of the disordered eating. So we kind of redefined the root cause of this condition as a notion of low energy availability. And we realized that this doesn't just happen on one end of a spectrum, but rather it is a spectrum. And there's a spectrum of energy availability with and without eating disorders. There's pure and absolute amenorrhea, and then there's subclinical menstrual disorders, and all the way to well-achieved eumenorrhea. And then there's osteoporosis, but then there's also osteopenia, low bone mineral density, and then optimal bone health. And so for that reason, kind of recognizing that these happen on a spectrum, as well as for a couple other reasons, we also realize that male athletes are also susceptible. And I am not going to tell you that that's a problem of menstruation in males. But we recognize really that testosterone is actually negatively impacted by this energy availability as well. And for the very unfortunate consequence of female athlete triad, the acronym of FAT, probably not ideal for this condition, focusing on body weight, we rebranded this as relative energy deficiency in sports. And I think that's well defined in this quote here from an article in 2014. The syndrome of Red S refers to impaired physiological functioning caused by relative energy deficiency and includes but is not limited to impairments of metabolic rate, menstrual function, bone health, immunity, protein synthesis, and cardiovascular health. It's a lot more far-reaching than we recognized. And I think that's well depicted on this graph here. So if we zoom out on this previously myopic view that we took with the female athlete triad seen in that red triangle, and we put low energy deficiency, or low energy availability, in the center, we recognize that it actually negatively impacts almost every organ system across the body. It impacts immunological function, endocrine function, metabolic, hematological, growth and development, cardiovascular, GI, and we also recognize very importantly that there's often this bidirectional relationship with psychological or mental health. And how that impacts athletes is much more profound than we originally knew. It can decrease training response, impair judgment, decrease coordination, decrease concentration, cause irritability, depression, decrease glycogen stores, decrease muscle strength, decrease endurance performance, and most relevant for us in the sports medicine community, increases injury risk. And that's how these athletes are often presenting to me or others in the sports medicine community, is they often are sustaining stress injuries or stress fractures. And oftentimes it's those athletes that have multiple stress fractures where that's that kind of oftentimes first clue that there may be something more systemic that's underlying these repetitive bony injuries. So let's redefine low energy availability. Very simply put, it's a mismatch between an athlete's energy intake, their diet, and energy expended in exercise. And I'm talking about all of these far-reaching effects. It would be wonderful, right? We should screen all athletes. What is their energy availability? Easier said than done, unfortunately. There are no real reliable tools to measure energy availability, and it's very unfortunate because we've talked about how really profound an impact this can have, right? It can impair recovery during training and from a previous injury. It can impair glycogen storage and protein synthesis. It affects both our anaerobic and endurance sport athletes, and as well as our aerobic and fast twitch athletes, right? It prevents consistent and often high quality training due to that repetitive increased risk of injury and, believe it or not, illness as well. So in terms of how we can prevent this condition, I think we're doing it right now. Increasing awareness is the first step, right? So you are all now educated on Red S, and let's spread the wealth, spread the gospel, right? So, and certainly if there's individuals or teams that you identify as being more susceptible to developing Red S, education goes a long way, right? So I really believe it's very important that adolescent athletes are receiving education on what is a healthy and adaptive nutritional program, right? What's healthy, what's unhealthy for them to engage in. In terms of screening, again, we have to have a critical eye. We have to keep an eye out for, now that we know which athletes are susceptible, we have to really be aware of when some of those athletes may be presenting with some of those more far-reaching presentations. And if they're having a couple of them and something's not quite adding up, consider Red S as a potential underlying etiology. certainly if there's any athletes that are presenting with obvious concern for eating disorders, we need to address that, right, with the proper screening tools. There are various questionnaires that are in production that may be of use in the benefit in helping to further screen for Red-S, but right now it really takes a kind of watchful and careful eye on everyone's approach. Now, in terms of treatment, I think the treatment is maybe a little bit beyond the scope of this topic, but I wanted to kind of just focus on the non-pharmacological treatment. So first and foremost, right, we've talked about the root cause being low energy availability. We need to correct that deficit, right? So that comes via modification of exercise and improving nutritional practices. Usually that's with the help of a dietitian. Bone health is paramount, as we've talked about, so supplementing with calcium and vitamin D can be very helpful in restoring that healthy bone. And then we talked about the interplay of psychological and poor mental health and Red-S. And so oftentimes various forms of therapy like cognitive behavioral therapy can be very useful. Ultimately, this is a very complex and far-reaching condition, and ultimately it takes a multimodal and team approach to really optimize care in these patients. So they're coming to me with stress fractures, but I'm often referring to endocrinologists for further testing, potentially OBGYNs, often nutritionists, right? Physical therapists to help them recover from their injuries, and also potentially recognize other underlying deficiencies, thanks Tom, that may be predisposing them to these injuries in the first place, right? So it really does take a team approach to recognize this condition, restore them to this optimal balance, and then get them back on the right track. And that's all I have for you today. Thank you very much.